What I'm talking about today is the Women's Empowerment in Nutrition Index, and this is work that's been funded by UK Aid. We're one of the Round 1 EMANA grantees. What our objective is with WANI is to measure nutritional empowerment to better link agriculture to nutrition. We have a large research team. So what is women's nutritional empowerment? Well, we've defined it as the following. It's the capacity for a woman, and not just her children, to be well-fed and healthy, to have a meaningful say in household nutritional practices, and to receive support in them. Now, this is a really big definition. It's pretty hard to operationalize, so part of what we've been spending our time doing is thinking through how we might want to do this. We use as our starting point Naila Kabir's 1999 discussion around empowerment, and she makes a point that empowerment not only is a process, but includes resources, agency, and achievements. So what's our approach to operationalizing this definition? Well, first we've been doing formative research on what I'm calling, in air quotes, overlooked factors. Much of this work has been done, but much of it's been qualitatively based, and we're now trying to figure out how do we move that into quantitative surveys. Secondly, we're then going to generate the WANI and validate it. So the way we're doing this is we're first reviewing literature, surveys, we're doing some ongoing quantitative work. The stuff in black means we're working on it. Stuff in blue means it's yet to come. And we're also doing community-based research to identify factors that may influence nutritional empowerment. And this is what I'm going to focus on today, qualitative findings from discussions with community members. I would encourage you all to look at Paprocki and Khan's 2014 for more information about community-based research. We also will have a paper coming out, we hope soon, on this topic. So once we do this formative research looking for overlooked factors, we're then going to develop the WANI index and try to validate it by examining its ability to predict the nutritional status of women and their children. And I want to point out we're very much focused on women. We think there's a fair amount of discordance. So sometimes children might be doing quite well, but their mothers may not. There's some studies coming out of sub-Saharan Africa that find substantial differences in nutritional outcomes between husbands and wives. So how are we thinking about how to actually turn WANI into an index that we could potentially measure? Well, we're starting with Kabir's dimensions of empowerment. We're pulling knowledge out as a separate from resources because we think in some ways to access resources you need to know of their existence. And we're applying each of these 4 dimensions to a variety of different domains. We're looking at the food domain, the health domain, and fertility for women for whom that matters, work, as well as structural conditions, support, and institutions. Our quantitative work is going to help inform our intermediate achievements, for example, dietary diversity around the food domain. Ultimately, we're really interested in, as I've mentioned, nutritional outcomes of women, measuring things like BMI and anemia. I can talk more about this slide at the end. There's a lot going on. There's also a lot going on in this slide. This slide is talking about how there's a really rich literature on factors influencing nutritional outcomes, especially around children in South Asia. I'm not going to read this. Many of the authors are in this room, which is quite exciting. I think the point is to say that there's a lot of things that we know, and there's a lot of quantitative measures that are out there. And so now we're looking for things that maybe we've overlooked in the past. So the quantitative literature gets at lots of different issues, but of course it can't cover all aspects, and that's the nature of the existence of surveys, how do we operationalize measures, etc. So quantitative models do explain up to 30% of the variance in stunting rates and up to 50% of improvements. And so we're really excited about this is great. Can we build on this? So what we ask is, are there overlooked factors that influence nutritional empowerment of women that they themselves identify as important? And for us, it's really important to get the perspective of what community members feel are driving their own challenges around accessing good food, health, etc. So we're focusing primarily here on attributes of not commonly included in the quantitative studies. So if you read really fast, all the stuff that's on there about maternal height, parental education, income, assets, I'm not going to talk about that because we already sort of know, it's well established that those things matter. So what is community research? Well, we chose 3 sites in South Asia, and we worked with several NGO partners, including Ijirakori, among others, Agramagami, Pradhan, Onwesha, and Sambhav in Odisha, as well as JJS in Bihar. How did we do community-based research? Well, it's challenging, but it's also really, really exciting. So what we do is we work with civil society to identify some of their own members. We train those members in research ethics, audio, how to use audio recorders, in techniques to do semi-structured interviews, open-ended interview techniques, looking around questions of nutrition and tensions within households around decision-making ability. They then go back out and interview members of their own communities. We did lots of interviews. The challenge with this technique is it isn't always perfect. Some of the interviews aren't going to be that interesting, and some are. And what we did was we primarily focused on marginalized populations. So what did we find? Well, I want to talk about two main categories. The first is thinking about structural conditions, support, and resources. The second is intra-household allocations. Now, why might we care about structural conditions? Well, something that's very common in the quantitative literature is to use fixed effects. And I love them. But I think there's sometimes something interesting about, can we pull information that might otherwise be captured as a fixed effect into a survey to get us a better sense of how people are engaging with some particular norms, practices, or structures. So let me give you an example. Common pool resources. Using a fixed effect in communities in Odisha would kind of absorb some of this, but what we're finding in our study is that people engage with common pool resources within the same community quite differently, and as well as across communities. So one respondent explains, Siali creepers are used to stitch leaf plates, which is a source of income. She says, quote, if one Siali creeper grows up, then we destroy it to make the rope. In that way, Siali creepers have gradually been depleted. So we took a decision to not to collect plants for the last 2 years. As a result of this year, some women were able to get leaf. Last year, we were not able to prepare a single leaf due to the shortage of leaves. So what does this mean? Well, it turns out across our interviews, we find that women face very variable access. Some women are walking 2 kilometers to the jungle to get leaves, some are walking 4. Some communities have the resources entirely depleted, others do not. And common pool resources are not only important for income in Odisha, but also dietary diversity and forest foods during lean seasons. So what we're seeing here is if we think about incorporating common pool resource accesses into surveys where they might matter, we're going to get some variations, which I think is pretty interesting. Another example is arsenic in groundwater in Bangladesh. Arsenic is more prevalent in some parts of Bangladesh than in others, but even in areas where it's prevalent, people's exposure to it varies. So a pregnant respondent explained to us that her family has a tube well that tested positive for arsenic, and so it has a red tap. Arsenic wells that are good have green ones, the ones that are tested that are bad have red ones. As this indicates it's contaminated. No other offers of remediation were made by the folks who tested it. They came in, tested, and left. At the time of the interview, the respondent's family continued to drink from the well because although they couldn't afford to purchase filters or to dig a deeper well, although they knew it was bad for their health. Right, and so this isn't just about assets and income, right, but it's also about this sort of access to clean water, some of which varies by household. So even some households in our sample who had red taps were able to go to their neighbors and access their water, right? Other households who had red taps didn't have that kind of reciprocal relationship with their neighbors and were essentially drinking water they knew was poisoned. And so I think this is a question for us as we think about common issues existing in communities. We think there's nonetheless a lot of variation within household or across households' exposures to these sorts of factors, and as well as across various communities within districts. We also are quite interested as we think about norms. How do we capture some of these positive deviations from the norm? Because I think that's some interesting stuff going on. So the second thing I want to talk about is intra-household variation. The first is around health-seeking behavior. So I just want to say there's a lot of work around intra-household variation on who makes decisions about assets, agricultural productivity, et cetera. And that's all great. We think there's some other factors that we need to be considering seriously as well. So intra-household variation that we're seeing is quite substantial around the issues of health-seeking behavior. So we have one woman who said from Odisha, we give priority to male members of the household to be taken to the hospital, because if they stay free from disease, they will look after us. When female members are ill, mostly we stay at home and take home remedies or procure medicines locally. Right, and so here there's this differential access around healthcare within families. We find similar things for food allocation, and the point is it's not only gender, it also matters around age. So maybe daughter-in-laws are more likely to eat less. We also see a substantial amount of domestic violence. And so the point I want to be making here is that while surveys around nutrition are often only once or twice a year, it's the women themselves, particularly young women, who are absorbing the differential effects of intra-household access and declines. So during lean seasons, when there's shocks, when there's violence, when there's inadequate food, we're seeing that women are the ones who are suffering most. And this resonates with the Lancet findings from yesterday, where women's BMI declines more during lean season than their partners. So where does this leave us? These are our two main findings. We're now looking at unpacking these and trying to capture norms and deviations. We think seasonality is critical, and we need to know not only when people are coping within a household, who is the one who's absorbing this. So the consequences of seasonality shocks, access to healthcare, and environmental factors are different for women than for others in the household. Where do we go from here? Well, we're trying to operationalize these findings in quantitative surveys, and our next step is to construct and validate the WANI. So stay tuned, and thank you all.